Hi, everyone. Let's talk about feeding and eating disorders, which is chapter 16 in your Polar book. And with this chapter, you're going to learn about the major features of the most common feeding and eating disorders, causes of those disorders, assessment findings, nursing interventions, and recommended treatment for patients. So let's take a look at eating disorders. They are a serious and sometimes very fatal psychological and medical illness that's associated with persistent and severe disturbances in a person's eating behaviors and related thoughts and emotions. Eating disorders impact a person's physical, emotional health, productivity, relationships, with others. An individual with an eating disorder is preoccupied with thoughts of food and weight and body shape to the extent that it actually disrupts their daily life. Serious and life-threatening consequences occur if the condition is left untreated. Several different feeding and eating disorders have been identified and classified by the American Psychiatric Association, and it's based on the presentation of symptoms. Although some individuals only present with partial symptoms of a disorder, they could have a subthreshold or a subclinical, but they still require treatment and interventions. So, about 30 million individuals in the United States suffer from clinically significant eating disorders at some time in their life. Subthreshold eating disorders may be as high as 11% of the population. Eating disorders can occur in all ages, affect both genders, and can be found in all ethnic groups and backgrounds. The symptoms most frequently appear in adolescence or young adulthood and then generally begin between the ages of 13 and 17. Eating disorders are the third leading type of chronic illness of children and adolescents. Females do have a significantly higher incidence rate of these diseases. So let's talk about anorexia, bulimia, and binge eating disorder. Eating disorders occur on a spectrum of severity from mild to severe. All three of the most common eating disorders that I stated previously involve some sort of disorganized eating pattern. In some individuals, the specific type of eating disorder can change over time. So, for example, a person with a diagnosis of anorexia may actually begin to binge and purge when weight is restored. There can be a significant overlap of symptoms between all three eating disorders. These disorders can be physically and psychologically debilitating. Extreme cases can lead to death from physical complications or perhaps suicide. Eating disorders have the highest rate of mortality than any other psychiatric disorder. As with other disorders, early recognition and treatment leads to better outcomes. Long-standing illness and comorbid psychiatric problems such as substance use disorder, depression, anxiety, obsessive compulsive, personality disorders, they can all complicate the treatment and they tend to have poorer prognoses. So, looking at causes. Currently, the cause of eating disorders involves a complex interaction of genetics, biological and psychodynamic factors, as well as social and family influences. Now, looking at genetic and biological theories, eating disorders have about a 50 to 70% genetic contribution. Eating disorders tend to run in families. There's a higher rate of eating disorders in mono twins than in, so we'll say, in identical twins versus fraternal twins. Some behaviors associated with the eating disorders are linked to specific chromosomal anomalies, gene mutations that affect the hormone functioning and the neurotransmitter regulation. We're talking about serotonin, norepinephrine, and dopamine are implicated in these diseases. Neuroanatomic brain changes are also seen with these disorders. So, what are the risk factors? That increase susceptibility for feeding and eating disorders. Gender, being female. Age, being an adolescent or a young adult. Looking at family history, having a sibling or a parent with the eating disorder. parental over concern with their child's weight, history of mood disorders or substance use disorders, psychological history, concurrent depressive disorder, anxiety, mood, OCD, or personality disorder, history of a childhood depression or anxiety disorder, personality traits of high anxiety, perfectionism, low self esteem, high achievement orientation. There's conflicts over identity, sexual identity, role development, body image. Could be a history of trauma, physical, sexual, or severe neglect. Could be situational. They're transitioning in life, such as moving, beginning college, other significant life changes. Social, being an athlete, an actor, a dancer, a model, or profession in which weight and appearance is very emphasized. Interpersonal conflicts, especially with bullying about weight in children and adolescents. In addition to the risk factors, adolescent girls with type 1 diabetes are twice as likely to have a disorganized eating behavior than their non diabetic counterparts and may omit insulin as a weight reduction strategy. We have social influences. Society sets, these unrealistic expectations for appearance, equating thinness with being successful, being powerful, being popular. And these expectations are conveyed through images of these thin, beautiful women on television and in films and magazines and social media. Common indicators of feeding and eating disorders include dramatic or frequent fluctuations in weight, eating differently than the rest of the family, avoiding food, secretive eating, dieting, extreme food restrictions, rigid eating rituals, preoccupation with food, with body shape, with weight, expressing excessive body dissatisfaction. They are doing secretive exercise. They have feelings of guilt after they eat, and they frequently weigh themselves. So, in anorexia nervosa, that's a syndrome in which the affected person relentlessly pursues thinness, sometimes to the point of emaciation. They become preoccupied with food and body image, and despite them being extremely thin, they perceive themselves as being overweight and they have a very distorted body image. This syndrome characterized by extreme self-induced starvation, excessive weight loss. We get metabolic abnormalities. So we generally deem the person to have anorexia nervosa when the body weight is significantly below expectations for the person's age, height, development, and health. There's subtypes that are recognized by the APA. And we have restricting, which is dieting and fasting. And then we have binge and purge, where episodes of eating large food followed by behaviors such as self induced vomiting to help prevent weight gain. So many people confuse the medical terms of anorexia nervosa. So AN is the clinical term for anorexia. So in reality, the two conditions are actually not the same thing. Anorexia refers to loss of appetite and a common symptom of any GI disorders, endocrine disorders, cancer treatments. Anorexia can accompany anxiety, chronic pain, poor oral hygiene. If you have a fever, you're in hot weather, age-related changes. Some drugs can even cause anorexia. But anorexia nervosa, the disorder itself, that is a eating disorder marked by distorted body image, extreme fear of gaining weight, restricted nutritional intake to maintain minimally normal body weight. So a person with anorexia nervosa perceive themselves as overweight even when they are not. So we have serious complications with this. Malnutrition, dehydration, electrolyte imbalances. We can have from prolonged starvation, vomiting, laxative use, diuretic use are all associated with disorder. Anorexia nervosa tends to have the highest mortality rate with about 10 to 20%, both from the physiological complications and the amount of suicide that occurs in this patient population. Prolonged starvation leads to a whole host of things. So we have psychological and neurological consequences. We can actually have acute cognitive dysfunction. So we have, let's see, cardiovascular complications of anorexia nervosa, very life threatening, bradycardia, hypotension, orthostatic hypotension, reduced cardiac output. They get cardiac palpitations and arrhythmias, usually caused by the associated hypokalemia. It can result in sudden death. Electro ECG changes, non-specific ST intervals, T wave changes, prolonged PR intervals, and we see prolonged QT intervals. We have a decreased left ventricular muscle mass and chamber size. People go into congestive heart failure and they have an increased risk of going into cardiac failure while they're in the refeeding process. Endocrine and metabolic, we get amenorrhea, so sensation of that menstrual period. That occurs in about 25% of patients. Estrogen deficiency causes reproductive problems, delayed psychosexual development. We get hypothermia, cold intolerance, increased growth hormone, cortisol, cholesterol, liver functions, abnormal blood glucose levels, gastrointestinal bleeding, nausea, constipation, abdominal pain, esophageal erosion, ulcers, tears, bleeding, as well as tooth and gum erosion and dental caries because of the excessive vomiting. Hemolytic issues, we can get bone marrow suppression. So we're going to have decreased white blood cells, decreased red blood cells, decreased platelets, decreased hemoglobin and hematocrit. This can lead to what? Susceptibility to infection, right? We get anemia, low energy levels, we get weak, we get bleeding, we get bruising. Fluid and electrolyte imbalances, we're going to get dehydration with poor skin turgor, dry mucosa, hypokalemia, hypomagnesia, hyponatremia, hypophosphatemia, metabolic alkalosis with the vomiting. We can get metabolic acidosis with reduced sodium bicarb related to over-laxative use. We can get peripheral edema. We can get renal dysfunction. We get increased creatinine, increased BUN, very diluted urine. We get mineral and vitamin insufficiencies. So osteoporosis is a big thing because we have decreased calcium levels. Decreased thiamine will disrupt the cell physiology. In your skin, your dermatological, dry, flaky skin, brittle nails, hair loss. They actually develop this thing called lanugo, which is that downy like hair that sometimes babies are born with. It develops because there's a loss of subcutaneous fat. We get neurological changes, vertigo, feigning, develop of rigidity of thinking, decreased concentration, confusion, clinical depression, high levels of anxiety, high levels of irritability. And during that refeeding process, when we're treating severely malnourished people, it requires very careful monitoring to prevent very life-threatening complications. So statistics on the onset, the prevalence of anorexia nervosa are very variable. It's estimated that the lifetime prevalence rate is about 0.3 to 1%, with some studies indicating the rate as high as 4% in females. And approximately 90% of those individuals diagnosed with anorexia nervosa are adolescent young adult women. Males and older and younger individuals of both genders can also struggle. Age of onset is generally between 13 to 17 years old. Looking at genetic contribution to this disease is about 50 to 80%. Anorexia nervosa is more common among sisters and mothers and of those also with the disorder when compared to the general population. Identical twins have a higher risk than fraternal twins. And then there's genetic abnormalities on chromosome 12 that have been linked to anorexia nervosa. Neuroendocrine theories identifying like hypothalamic dysfunction as a contributing factor. Neurochemical theories suggest that there's low levels of neurotransmitters like serotonin and norepinephrine, and they seem to be very prevalent in this population. Looking at PET scans, and CT scans, we have brain abnormalities. They are seen in individuals, especially when they are in that starvation phase. Behavioral and environmental factors. Because anorexia nervosa is more common in Western and industrialized countries, some experts blame the disorder on societal standards of the ideal body shape in contrast with pressure to be thin. Many people first learn about feeding and eating disorders from friends in the media, and some theorists believe that feeding and eating disorders represent learned behaviors in response to very strong societal pressures. Stress could play a role. As with any other psychiatric disorder, stressful events can increase the risk in someone who has genetic predisposition. Experts have observed low self esteem, perfectionism, sense of powerlessness in those who have a diagnosis of anorexia nervosa. It is believed that the disorder may be an attempt to defend against feelings of inadequacy. It is hypothesized that individuals with anorexia nervosa feel powerless, unable to control their life, unable to control the environment around them, and what can they actually can control is food. So they strive to regain this personal sense of power and control, and they do that through caloric restriction. The individual can come to believe that achieving this perfect body will lead to having a perfect life. And some psychiatrists see refusal to eat as like a subconscious effort to protect oneself from dealing with the issues surrounding maybe problems with their sexuality. Families with adolescents diagnosed with anorexia nervosa tend to report interpersonal boundary problems in which there may be like a separation and autonomy development issue. And other family factors that can play a role include like a family system in which one parent is dominant and the other parent is passive, or a family system that places a high value on achievement, or a family system that has trouble resolving conflict and expressing anger. Families often report feeling very powerless in the face of some of the behaviors associated with eating disorders, and it's unclear if some of the problematic behaviors observed in the family system contribute to the development of the eating disorder, or is it a result of the frustration of seeing a loved one struggling. So, key features of anorexia nervosa are self imposed starvation, despite the patient's obvious emaciation. We have significant weight loss with no organic reason, a morbid fear of being fat with frantic efforts to be thin. So, we look at the word hunger as your kind of memory jogger about the major features of anorexia nervosa. So we look at the word hunger. H has an obsession with food. U, underweight. N, nutritional needs not met. G, gross distortion of body image. E, exercise, vomits, use laxatives. Or R, refuses to eat. So physical findings: emaciation, skeletal muscle atrophy, loss of fatty tissue, breast tissue atrophy. They get that lanugo on their face, that very soft, fine hair. Dryness of the scalp, loss of hair on the scalp, low blood pressure, hypotension, bradycardia, irregular heart rhythms, fatigue, sleep difficulties, cold intolerance, constipation, bowel distension, loss of libido, and amenorrhea. Psychosocial findings: preoccupation with body size, distorted body image, extreme fear of weight gain, lack of insight. They describe themselves as fat. They have dissatisfaction with their every aspect or a particular aspect of their body. They have low self esteem, social isolation, withdrawal, perfectionism. There's a paradoxical obsession with food. There's a feeling of despair. There's suicidal thoughts. There could be self harm behaviors like cutting. So we have behavioral signs: wearing oversized clothing in effort to disguise the body, ritualistic eating patterns, behaviors to prevent weight gain, layering of clothing, are wearing very unseasonable warm clothing to compensate for cold intolerance. Restless activity, there's loss of vigor, there's excessive exercising, there's high academic, super high athletic performance. We always look at comorbid conditions because about half of the people diagnosed with anorexia nervosa also present with symptoms of at least one other psychiatric disorder. These include anxiety, depression, substance use disorders, personality disorders, OCD traits, rigidity of thinking are frequently seen in this population. So, although anorexia nervosa should be suspected in any young person with weight loss, healthcare providers often miss the diagnosis because the patient is very secretive about their symptoms. There's the SCOFF questionnaire, the SCOFF, is an example of a standardized, validated screening tool available to primary care providers to assess patients for eating disorders. And any two yes answers suggest a possible eating disorder and the need for a more in depth assessment. So we got this SCOFF. So sick. Do you make yourself sick or vomit after a meal? Control. Do you fear loss of control over how much you eat? Oh, have you gained 14 pounds in a 3-month period? Fat. Do you believe you are fat even when others tell you you are thin? And F, does food dominate your life? Complete physical examination. Laboratory tests need to be done. Laboratory tests are there to help rule out endocrine, metabolic, central nervous system abnormalities, cancer, malabsorption syndrome, something else that can cause physical wasting like HIV. And we look at deviations from the norm. In a patient who has lost more than 30% of their normal weight, um, could have below normal hemoglobin, low platelets, low WBCs, low RBCs. They could have low sedimentation rate, problems with creatinine, BUN, nitrogen, uric acid, cholesterol, total protein, albumin, chloride, calcium. Their fasting glucose will be off. Their luteinizing and follicle stimulating hormones will be off. Their T3, T4 levels will be off. They'll have prolonged bleeding times. They usually have an elevated amylase and usually very dilute urine. And we need to differentiate this from other medical conditions: GI disease, hyperthyroidism, occult malignancies, HIV, other psychiatric disorders that could present like anorexia nervosa would be substance use disorders, especially people who are abusing stimulants like cocaine or amphetamines, anxiety disorders, OCD, mood disorders, personality disorders, your borderlines, your histrionics, schizophrenia. The diagnosis of anorexia nervosa is based on the presentation of the symptoms. And then, although statistics vary, most people who meet the criteria for this diagnosis will not seek help voluntarily. And this is related to their lack of insight, the stigma, the shame associated with the disorder. The priority treatment aims to promote weight gain, correct malnutrition, normalize eating habits. It's important to resolve the underlying psychological, physical, interpersonal, and social issues that perpetuate the disease so the person could have long term recovery. The most effective strategy has been psychotherapy coupled with weight restoration to within 10% of what's normal for that person's height. An interdisciplinary team of medical and mental health clinicians and dietitians who have experience in treating anorexia nervosa will enhance the outcomes. So, we're going to do refeeding consisting of a reasonable diet with or without liquid supplements, vitamin and mineral supplements, activity curtailment. We got to watch for arrhythmias. We do group, family, individual psychotherapy, behavior modifications, and then they get privileges based on weight gain. Patients are usually successfully treated as outpatients. However, there are patients who will need to be hospitalized in a psychiatric stabilization unit. So anyone who's like rapid weight loss of 15% or more of their body weight, persistent bradycardia, systolic blood pressure of 90 or lower, hypothermia, less than 97 degrees Fahrenheit. If they have other medical complications, there's they keep failing outpatient treatment. They have a denial of their disorder. If they're at risk for suicide or they're having self-injurious behaviors such as cutting, then they're best not to be treated as an outpatient and they would do better in an inpatient unit. And then all forms of psychotherapy, psychoanalysis to hypnotherapy have all been used in treatment of anorexia nervosa. They all have kind of varying success. To be effective, psychotherapy must address the underlying problems of low self esteem, guilt, anxiety, depression, disorganized perceptions. Psychotherapy is aimed at helping the person develop a more constructive, non food related coping skill. So we look, common things we look at is CBT or enhanced CBT, or cognitive behavioral therapy, is specifically designed to challenge the cognitive distortions associated with eating disorders. So we're helping the person learn how to think differently about weight and body image. ITP, interpersonal psychotherapy, is aimed at improving interpersonal relationships, very effective to decrease symptoms. We do family-based therapy to involve, the family members as a whole or as a part, and offers very effective treatment for adolescents. There's no definitive medication that improves the symptoms of anorexia nervosa. Antidepressants can be used to treat comorbid conditions. There's some evidence that suggests that low doses of antipsychotics, such as olanzapine, can help reduce that ruminative thinking about food and excessive levels of anxiety about weight gain. Um, Problem with olanzapine, though, is it causes weight gain, so I'm very mixed about the use of that drug. All nursing interventions start with the development of a therapeutic nurse patient relationship, and this is true of individuals with eating disorders. It was found that the motivation for patients to adhere to treatment was likely to increase when the nursing approach was very person centered and when the nurse's attitudes were characterized by the presence, their genuine commitment, and their motivation to the patient. Specific nursing interventions that will facilitate recovery, regular monitoring of vital signs, nutritional status, fluid intake, fluid output, regular assessment of skin turgor, looking at mucous membranes, determination of, with the patient and the healthcare team, what is a target weight, and let's support that person's target and their efforts to achieve that goal. Some programs use behavioral modification approach to support weight gain. Unit privileges, such as getting to do certain things and participate in certain things, can be taken away if a person does not gain weight. The nurse can explain and support the plan to facilitate treatment adherence. We're going to monitor the patient for passive or active suicide potential for self harm. Weight gain can increase these urges, especially right early in the early stages of treatment. So it's important that we recognize that the patient's greatest fear of weight gain may interfere with their achievement of treatment goals. Lack of treatment adherence can be frustrating to the nurse, and to the significant others and family. So empathy, respect, ability to be non-judgmental are the essential components of a supportive nurse-patient relationship that can actually lead to better outcomes for these people. So, person to person, maintain that one on one supervision of the patient during meals. It's 1 to 3 hours afterwards to make sure that they are complying with their dietary treatment program and they're not vomiting as a way to maintain low weight. Food is considered a medication for these patients. The person is usually given a limited amount of time that they need to complete their meal. It's usually 30 minutes. Food choices must be done in conjunction with a dietitian to prevent reinforcing any kind of dysfunctional eating patterns. We're going to allow the person to exercise control when possible over non food related activities in a therapeutic environment. And then be aware during that acute anorexic episode, nutritionally complete liquids are sometimes more acceptable because they don't require the patient to select food. These patients, they find choosing food to be very, very difficult. If tube feedings or other special feeding measures become necessary, we need to explain these measures to the patient, be ready to discuss their fears. Why are they reluctant? And then never, we don't want to ever like limit the discussion um, to food itself. So weigh the patient daily after they void, before they eat. And it's on the same scale at the same time in the same clothing. Before weighing the patient, we're going to monitor them closely. Patients may hide objects in their clothing or drink large amounts of fluids to falsely increase their weight. So keep in mind that a patient's weight should increase from morning to night and anticipate a weight gain of about 1 to 3 pounds a week. If edema or bloating occurs after resuming normal eating behaviors, reassure the patient that this is temporary and it is very normal. Otherwise, they may fear that they're getting fat and they may stop complying with the treatment. Encourage the patient to recognize and assert feelings freely. If the patient understands that they can be assertive, they may gradually learn that expressing their feelings will not result in losing control. Explain how improved nutrition can reverse the effects of starvation and prevent complications. So remember that patients with anorexia nervosa, they use exercise, preoccupation with food, rituals, manipulation, or mechanisms to preserve the only control that they think that they have in their life. If a patient requires hospitalization, maintaining contact with the patient's outpatient treatment team can promote like a smooth transition when they go back to the outpatient setting. Patients and families can benefit from therapy that assists the family, significant others to develop strategies for improved communication and to search for ways for them to be more supportive to the patient. Families can frequently feel a lot of guilt about their loved one's illness. So it's important not to assign blame to a person or blame to a family member. Patients are not responsible for causing the illness. Families are not responsible for causing the illness. Um, but everybody should be participating in the treatment and recovery. So give your patient and family, and we use the memory jogger of CUES, CUES, to eating disorders by covering these topics during your teaching. So C, causes of eating disorders. U, understanding how to overcome power struggles. E, effects of the eating disorder on the physical and mental health. And S, symptoms of eating disorders and signs of relapse. And that is it for anorexia nervosa, and I will be doing another lecture on bulimia.